And I'd like to introduce you to our final speaker for this session. Jie Chen is from the University of Maryland School of Public Health and does a lot of work on dementia in a lot of different ways. Very, very interesting. And she is not going to say too much about her, but that she's going to be presenting to us one of the applications she's done. And so
thank you so much. Yeah, but actually, Igor and John play the perfect setting for me for my talk today. But I can save a lot of time because I think that my talk basically will talk about the application of the Ohio line decomposition to ADRD research. Okay, so here we go. So my research is supported by NIA. So we have this happy lab called the Hospital and Public Health Interdisciplinary Research Happy Lab. So why do I say that? Because by reading the name, you would know my research is a little bit different than previous speakers this morning. So I'm more looking for the health system, the healthcare delivery system, to see how the hospital can work with the neighborhood or public health. So we can provide the coordinated care, so we can let people happily live in the community. So happy aging is what I pursue. So basically, what I'm really looking for is the population health. I do believe we need a comprehensive care coordination model to promote population health, which can be cost-effective in this. So we focus on cost for the mental illness, geriatric mental health first. Then we find that, yes, actually integration of the public health system in the hospital can really work and save money and reduce a lot of the avoidable ED visits and so forth. So we say, given the dementia population who have multiple chronic conditions, right, who can really benefit this care coordination and integrating the system, why don't we apply the model to see how this dementia population, can benefit from this model? That's how we develop that. So here is a map of the care coordination strategy I mentioned. So basically, you will see like a lot of diversity in the US. So this different color mentioned indicates the poverty line. So red color, you probably could have guessed, right? It's the poverty areas in the United States. And then the circle, the size of the circle indicated the care coordination measure that can be applied in the area. This measure can be applied, obtained from the area resource file. So you will see the larger the cycle means the more innovative approach care coordination strategies available in the area. And otherwise, yeah, so you will see, in other words, I'll try to see, I'll show you that's the red smaller dots are more often. In other words, in the high poverty areas, you often see fewer care coordination strategies or activities. That's very surprising. Like this, I think the map is better. Okay, so so there is a lot of empirical evidence to show that the care coordination is related with the equitable fashion, right? So usually African American Latino populations were less likely to receive the care coordination, interventions, although they can really benefit from such care coordination model. But so we have this happy module which I presented and made some last screen. So basically, we really think, as an economist myself, I believe in triple aim. So we want to improve quality, and then we want to improve access. And meanwhile, we want to reduce the cost. Okay, and I do feel that the fourth aim, which is the health equity, I may be naive or more passionate to believe that if we can really design the delivery system in a better way, more actionable way, there is a way we can really reduce cost without sacrificing access or quality. So that's the outcome I would like to pursue. So in this module, I adapted the WHO structural racism discrimination model. So you will see there are a lot of factors that can influence the outcomes. Okay, so basically it can be the interpersonal level, your own health needs, right? My biomarkers as we presented this morning, and it can also be the interpersonal. As I went to see my doctor, how my doctor treated me. Okay, so interpersonal or how I working with my neighborhood, my neighbors treated me. So interpersonal level, and then more importantly, because I work more on the care coordination, so I'm more interested in the structural level. In other words, where is the healthcare, the healthcare access, right? The social determinants of health and other institutional racism that exist in the area. And then the good news is that this is not like a fix. There are a lot of modifiable factors we can do to address this. So for example, I personally in my early study we do a lot of patient-centered care. to see how that will can empower patients. And then we do care coordination and the reimbursement model, like the ACOs I will talk about in a few slides. And now another thing that I will talk about, there are a lot of ways, as I mentioned, can not solve, but try to answer these questions. So I use the market level model mainly, but I think the decomposition actually is another way that you can apply it, because there are so many factors. You might be interested to see how can I apply the decomposition approach so we can know which factor explain which, whether there are more percentage can be explained by system level or by the individual level factors. I think that can be a really nice way to use it here. So I will give some examples. First, I will talk about how we can, kind of underneath this model and apply decomposition to explain racial and disparities. So the paper I will talk about mainly is to apply the approach for to understand the preventable hospitalizations, okay, for people with AD, Alzheimer diseases. So why no PPH, preventable hospitalizations? Okay, so you will see, yes, I can be quick because I think we all know the literature, because for preventable hospitalization, first of all, it can be prevented, okay? If people have, good treatment, the timely treatment, etc. However, we also know, like many of you have mentioned, people with AD have multiple chronic conditions, diabetes, diabetes, right? So often, when you see people in preventable hospitalization, many people have ADs. So, and then there's huge disparities. Okay, usually African American, Latinos have more, and because of all sorts of reasons. Okay, access, treatment, quality, etc. And the literature has shown that care coordination can be useful, to, for example, if people can have received more timely care in the neighborhood, or if they are discharged, they have been followed up or receive enough referral, right? They probably, they don't need can avoid the PPH. And so this variable that we look for in this paper is the accountable care organizations, which is a kind of reimbursed module. So we think it is a virtual integrated network, which will integrate the doctor, the hospital, and the neighborhood function as if it is their, a care coordination teamwork. So people will be able to receive, the good care, and after they were discharged from the hospital. So we actually have done several other studies to see hospitals, ACO, participating characteristics, etc. But in this paper, we kind of see the ACO looking at the proxy for the care coordinations, that hospital provided to see whether they participate in the ACO, the network. And yes, the evidence of evidence also shows that minority population can benefit from the ACOs, but we don't know how this model can help address some of the disparities for the people with AD, which I would hypothesize probably they can benefit more than others, because there's a complex health needs population, right? Especially for minorities. So this study was published several years ago. We used the 2015 HCUP data from 11 states, so it's a hospital level, it's a hospital discharge data, and then we obtained the hospital characteristics from the AHA survey. We do the linkage. So we focused on white African American and Latino populations aged 65 and older. They all have a AD diagnosis, and they're all community dwelling. Then for the PPH, we use the AHR2 index. So mainly we focus on beautiful chronic condition mainly for AD, the diabetes, hypertension, asthma, and the heart failure. So it's a 0-1 if you have PH or don't. So the ACO, so I will acknowledge this. So in this paper, the ACO affiliation is the hospital affiliation. So whether the hospital is affiliated with ACO or not. So yes, and some limitation in the study, but it's early, so we didn't have data of the ACO at that time. Later on, we added. Okay, so it's the ACO affiliation, but mainly we also control other covariates in the full model. So basically, the full model is derived from the literature. So what are the factors that will influence your PPH? So basically, race, the age, health condition, the income, and the hospital characteristics. We also use the state indicator. So we have these methods. First, you do logistic to see what predictors, predict the PPH. Then we use the decomposition. Okay, we actually did a lot of sensitivity analysis. But I will just present the main point. Yeah. Oh, yeah. So another thing, just mentioned here is the Okaha decomposition. And mentioned that before, this method can be really applied in many ways. But in this study, we basically to see basically, this is we use the fairly, which is a nonlinear regression, because our outcome basically is logistic 0, 1. Okay, so basically we run the regression for white and for African American. Then we have these equations, then you minus each other. Okay, minus each other, then you rearrange the terms. Okay, so some of the differences is derived from X. Right, so maybe one is the older group, one is the younger group. So these differences it can be observed. So we call it the observable factors. But some of the factors you cannot observe these are from the coefficients. Okay, so these are called unobserved factors. But either way, you can rearrange the term and then you can tell the story. So let's see. So what do I have? So first, I will be very quick. So these are the 3 different racial ethnic groups we look at. So you will see basically compared to white African American Latino populations were less likely to be treated in hospitals with ACO affiliation and more likely to have the PPH. The difference is not that it's significant, but it's not that big. But anyway, so we're talking about the methods here. Okay, so let's see. And then we also tried a lot of different, analysis. But anyway, we do find that hospital affiliated with ACOs were less likely to have PPH. Okay, so now the question comes. So now, yes, looks like the hospital ACO does work. Right, but we also found that region the differences in PPH, and they also were likely to be treated in hospitals less likely to have the ACOs. So how this differences will explain the PPH, right? So let's see how do we do. So we just apply the decomposition method. So this is what we have. So basically, we first predict the PPH for white and African American first, right? So we find that there's a 1.8 difference. So African American population were 1.8% more likely to have the PPH. Okay, then our entire model explains 9% of the differences. So the entire model, meaning all the variables that we control for age, gender, health condition, state, etc. Okay, so the model is, I guess, not perfect. Okay, so all these variables you explain only explain 10% of the difference. However, actually, we have been using decomposition method for many years. before we using for the Asian population, we were a lot of the Latino African American. 9% is not a lot, but actually it's a reasonable range according to all the decomposition method, because racial disparity, there are a lot of things cannot be explained. So yeah, let me talk about the interpretation later. But generally speaking, the model explains 10%, observe the factor. In other words, 90% cannot be explained. But what we are interested in the ACOs, right? So hospital ACOs only explain 3%. It's significant, but 3%. In other words, for American, if they were more likely to be admitted in hospital with ACO, like the whites, the PPH of African American will be reduced by 3%. So that's the interpretation of the decomposition. Okay. Now, yes, 3% it is significant. However, there are other factors probably work better. Not work better, more important. Like we observe terms of the state variation. Okay, so you probably will see that African American or Latino population living in Florida. The environment they face will be different, like in Arizona, something like that. Okay, then. If you look for African white versus Latino population, then actually hospital ACO affiliation doesn't explain anything for the Latino population. Okay, but what is more important for that? That's actually the health condition. Okay, so you will see the health condition here is a negative sign. It's 50%. What does that mean? Actually, if you look for our data more detail, you will see compared to white population, Latino population younger, healthier. Okay, in other words, that's probably the reason we have lower PPH. Okay, if this effect is the same, in other words, Latino and white have the same health condition, you probably want to observe their PPH will be higher. Okay, so that's the negative sign meant. Okay, and then again, you observe enough variation by states. So that's what this model means. So basically, it says, looks like ACO works. However, there is huge differences, right? So in other words, we find hospital ACO affiliation explains 3%, right? It's not a lot, but it's still significant, but we were not able to explain the wider Latino differences. Perhaps because the Hispanic paradox, that part I'm not sure, right? But I think this is the HCAP data, so we don't have enough measure on their socioeconomic status. In other words, we cannot tell their education or others. Okay, so probably that's why the model didn't explain the differences very well. I do want to acknowledge there are a lot of state variation in the data, so that I think not focusing on, but further study on the state policy might be important, especially for AD population. So there are support for family caregivers, right? How these long-term care, they vary by states. I think these are worth studying. Another thing I do want to mention is that, as I mentioned before, our model explain approximately 10% of the differences. So more studies should be can be studied. So what are the rest of 90%? But honestly, if you want to figure out the rest of 90%, you really need the data to measure those unobserved. Right? Everybody can tell you have factors. I think that matters, but it has to be in the data. So that's what I will talk later. But anyway, we do have some limitations. First, it's only from 11 states, and it's cross-sectional, and then the ACO is only a proxy measure, okay, for calculation at the hospital levels. Then, yeah. So because this is the method session, right? So I want to talk about the application. So this is the one application, but let's just generate ideas, okay? But you can also apply the method in other studies. There are some more studies that we applied the decomposition to study the racialness disparities But our focus is the health integration, is the local health department mental health activity. So to see whether the community, right, local health department really advocates for mental health and mental health integration, how that will address the disparities. Okay, as we did before, we also observed huge racial disparities in PPH by race and ethnicity, right? But instead of focusing on hospital, let's look at the community. Do we have a better answer? Actually, I think we do have a better answer, not that better, but yes. Actually, our model, by adding the more local neighborhood factors, where we actually could explain like 69% of the model. So the difference of this study is that we added a lot of the neighborhood characteristics and the ADIs and all these things, and then we only observed but basically focus on the local health department factors. Well, it's not a lot with the 8-9%, but the model has been, I feel like, if you're looking for the community neighborhood factors, maybe it's necessary to do that. And another thing I do want to mention is that urban rural disparities. I personally feel if the decomposition approach can really be applied and have a great future potential if you want to study urban rural disparity. So we're looking for the telehealth adoption by urban and rural. As you will see, rural hospitals were less likely to do that. And then if you similar idea, okay, if you apply the decomposition and actually because a lot of the area differences, these measures can be measured. Okay, from whatever you're using ACS, using area resource file, can be measured. Okay, and it will be more objective, and which can be used to explain the model much better. Like the model actually, explain like 65%, of the adoption that have a house. Okay, so of course there are huge way. So what I'm saying, there's a huge potential. For example, you can also look for the intersectionality of the race and the rural area, especially for the telemedicine health. Why minority population living in rural area were the most vulnerable populations. I'm still working on that, but we just looking. So very recently, okay, we linked the Medicare claims data from five years and SBI index and also the ACO population. But basically, you will see that people, minority people living in the most vulnerable areas will face significant higher costs. and then this course will never end, and it's sustained, okay? And then even after 3 years, because this is the 2020 data at the end, I cannot draw the conclusion, but actually you will see that this gap actually increase, okay? Our end year is 2020, I don't know whether it's because of 2020 or it's just because the gap increased. I'm happy to do more analysis to find out, but basically, as I presented before, I do believe that decomposition methods can be really applied in the system level interpretation. And our recent project is to elevate the model by focusing on health information technology, which I think there is a huge way to do. This is the main methods. As I mentioned, we're using CMS with a lot of the area resource file or other data to explain other rural or regional disparities, especially I think that this seeing it consistent with the guided model, which is a guided for dementia model, focus on focus on dementia and focus on the patient center and focus on care coordination and focus on the health equity. But I think everything eventually linked together. I think that the decomposition is one of the way that you may use to answer the question. Yeah, that's all. Thank you.
Time.
Yeah.
Any questions?
Yes, yes.
So you used this virally 2005 decomposition.
Yeah.
Is it logistic model?
It's
Can you comment how it works compared to usual Axarca blender?
Actually, I think how it works, the idea is the same. It's basically you have different logistic regression, then you subtract each other, and you rearrange the. Of course, he has this, I think, more paths to do that.
You subtract averaging and subtract.
Yes, yes.
And what's the Y bar in your formula? This is what's ratio?
Yeah.
Okay.
Any other questions? Yeah.
So there's a ton of studies and a lot of really interesting evidence. So I wonder if you could, and given your expertise on healthcare systems and delivery, I wonder if you could just step back and maybe, ponder or speculate for us what you think are the most important aspects of healthcare delivery systems for addressing disparities in ADRD.
Okay. Well, if you asked me, I do feel healthcare delivery system itself play a very important role because yes, I am an economist, but I also have I talk to patients in the neighborhood and others. Actually, the access is very, very poor. And the people, there's a huge barrier of cultural preference and also caregiver burden. That's huge. So I do feel, the care coordination, which can really make it patient centered and then link the caregiver and the patient themselves and the provider is what I feel can be really helpful for people with dementia. And then at the policy level, I think, if there is some kind of financial incentives to engage a provider, not just provider, and also patient and the caregivers, so they can all be engaged to work together with the care coordination, I think that would be good. Yeah.
Thank you.
Any other questions?
Sorry about that, but excellent. And of course, as a by statistician. First, I love your names.
Oh.
They smile studies were great. So from clinician point of view, working in dementia, first of all, what are the things that we do? We divide these patients in mild, moderate, and severe. So when you were looking at those, will you just lump sum AD and then looked at it? Because that will have an effect on hospitalization and prevention.
Yeah.
My second is, there's a move in our field, in clinician, the geriatric psychiatrist, we published in our journal. There's a big push. As soon as somebody goes towards more moderate to severe, to be put on hospice.
Yes.
Would it have an effect on the outcome you presented? So they don't. They are not going to the hospitals anymore.
Yeah, it's a very, very good point. And second comments, yes. So actually, there are tons of studies looking for the transition between the settings. the nursing care, hospice, home health, and hospitals. There are tons of literature there. So my study mainly focused on the community dwelling that prevented, but yes, okay. Now, for your first question, I'm always looking for some experts like you to guide me how to move the post-acute care to the early stage. I think that is very important, but as we mentioned that early stage is hard to measure, define, how you define people with dementia. But I think that if we can do those prevention early stage, that will be really cool.
Yeah, virology ultrasound was earlier
Yes.
available.
Yeah.
Experts.
Yeah,
With
exactly.
NCI and early dementia.
And we studied it, but and to the implementation, I think I will want to work with expert like
All right, thank you very much.